because Kathy DeAngelis, the editor, is independent and was willing to allow us to get it published. And it has these 7 principles, and what I'd like to do now is very quickly just dilate on each of these. The first is universal coverage. Now, the problem with universal coverage now is that everybody's in favor of it. AHIP, have you heard of them? America's Health Insurance Plans. The lobby group for the private insurance industry. They want universal coverage, provided that you're mandated to buy their product. Right? This becomes, even the AMA has come out in favor of universal coverage, but they only want to use a tax credit approach to this, not a single payer approach. So I think the most important words here, when you look at the legislation, does the legislation have automatic enrollment? Okay, what do I mean by that? Well, you go to the emergency room, they do their wallet biopsy on you, and they find out you don't have health insurance. Oh, wonderful, they say. Let's just sign you up right here, automatically enroll you. Okay? Is there any private health insurance company in the United States that would enroll you when you appeared in the emergency room? No way, right? So look for that set of words in any legislation. Does it have automatic enrollment? It's one of the interesting things in terms of the public option. Will the public option allow anyone who doesn't have insurance automatic enrollment? And then the other issue is this issue of all residents, okay? Because we do have a big conversation in this country now around immigrants, undocumented immigrants. Are they in any way going to be included? And I think there's a big argument from a public health point of view. I'm a subway rider. I want that person next to me that's coughing on the subway to in fact have health insurance so that they can get their tuberculosis taken care of, that kind of thing. So look for those 3 words, automatic enrollment, and does it cover all residents? The second principle is that it's got to be comprehensive coverage. No Swiss cheese policies here. Should cover preventive services, hospital care, physician, dental, mental health, medication, reproductive health services, and nursing home care or home health care. All medically necessary services. Would there be any exclusions? Yeah. I would exclude tummy tuck. I'd probably exclude Botox for wrinkles, things like that. I would also probably exclude private rooms in a hospital. Okay, most of our hospitals don't have that many private rooms, unless medically necessary. I'm in a room with him. He's coughing away, right? The resident physician comes in and says, hey, I think you could have tuberculosis. Well, get me out of his room. He's got a medically necessary reason to have a private room.
If I may, that little phrase has always caused us a lot of problems in terms of the kinds of health insurance policies we regulate or pass laws about, because, and it all started over 48 hours of aftercare for new moms and their babies.
Right.
Who determines that it's not medically necessary for the new mom to be there beyond 5 hours, have the baby and send her home? And that if medically necessary was a way of watering down what we really wanted to do.
Okay, well, you have a legislator who's really been coping with difficult issues of language, and there's no question that the other issue is how this gets decided. And is it decided entirely legislatively, or does one set up a coverage board?
Or is it at least decided by doctors and not by the insurance company?
That's the point. I would have, well, frankly, more than just doctors. I want a coverage board that has doctors, that probably has hospitals, but also has patient representation. Groups like the American Cancer Society, or groups that actually represent, potential patients.
When we talked about this in terms of pregnancy aftercare, in terms of mastectomies, we mandated a big 96 hours in the hospital. I sat at a health committee meeting and had a doctor on the other side say, well, you can send home a mastectomy patient. It's no big deal to change a drain. And you know something, he was lucky there was a barrier in between the two of us.
Right.
Because I might have cheerfully ended his career right then and there. But I mean, those are the kinds of issues that people have got to be aware of, and where the language becomes so important, as you are pointing out here.
Absolutely correct. Yeah.
Should the doctors have the last say on that?
Should the doctors have a last say? No, I think it again ought to involve, some kind of more democratic, patient-doctor involvement in these kinds of decisions. The third principle is that all of this should be publicly funded. That's why we're in favor of single payer. That's certainly the positive aspect, frankly, of a public option. Is that at least you want to be sure the public option, by the way, is publicly funded. Senator Schumer, I met with him just a few weeks ago, was advocating no tax money going into the public option. Well, what kind of public option is that? He's saying it ought to be based on premiums paid for by, in essence, the patient. Well, what we're talking about is publicly funded. We could use a payroll tax approach. But that's not strictly progressive. We could use more of an income tax approach, but we definitely don't want to use premiums, because premiums are really regressive. The president of the company pays the same premium for health care usually as the secretary, and yet their incomes are so widely different. What we want is something in which taxes would be earmarked for health care and put into a trust fund so the money doesn't run off, to bail out Wall Street. And this is just a proposal that we won't dilate on here because of time, that shows how you would do it using a payroll tax. We would argue, as I say, that it should be some combination of payroll and income tax. The fourth principle is that all of this should have low administrative costs, and that's where single payer trumps any other approach, right? Because the administrative cost and overhead of private health insurance is anywhere from 16 to 30%, and for Medicare, our one single payer program is probably between 2 and 3%. In this New England Journal of Medicine, and I don't know if you realize that that's our best journal in medicine in the United States. In this article, it is calculated that $300 billion could be redirected to pay for the uninsured and for the underinsured if we went from our multi-payer system and private health insurance dominated system to a single payer system.
Is that in the course of a year?
That's in the course of a year. Absolutely correct. And by the way, this article goes back again to 2003. We're up to about $400 billion if we trend that to present costs. Yes?
Could you elaborate on those administrative costs a little bit? What you say with HMOs, your administrative cost is higher because you have to hire so many people.
That's right.
There and say how much
and reject the bills.
Yeah.
Exactly. In fact, let me show you. This is our calculation, and again, a lot of numbers here about how those savings come about, but this was not done by somebody that's a single payer advocate. This is done by the Lewin Group, which actually has just been taken over by United Healthcare, a private insurance